Dear friends, introducing SICOT Pioneer, Programme of Innovative Orthopaedic Networking, E-Learning, Education and Research. What is SICOT Pioneer? A stratosphere built up of cloud and web-based infrastructure that enable communication, storage and on-demand utility of educational resource by and for our membership. The aim of the platform is to encourage cross-pollination and a virtual delivery of goals within the different pillars of the Education Academy and beyond for the global orthopaedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in June 2020 and consist of a variety of educational event formats that encompass all orthopaedic specialties, training, research and innovative practices.
A very good morning, good afternoon, and good evening, ladies and gentlemen. I'm Gaurisan Thivendran, consultant orthopedic surgeon from Singapore and the scientific program chair for SICOT. And it's an absolute pleasure to extend a very warm welcome from SICOT Pioneer to all of you logging from the various corners of the world. It's truly an honor today for us at SICOT Pioneer to host this second SICOT limb reconstruction webinar on our platform. This time focusing on the very relevant and very relatable challenge of performing surgery in a resource-limited environment. In usual style, we are truly blessed today to have with us a panel of world-class deformity correction surgeons who will share with us their experience through the next 6 different lectures, tips and tricks to offer bespoke treatment to each and every one of these very challenging cases. The webinar today will be chaired by Professor Hemant Sharma and Dr. Firas Sulaiman. Professor Sharma is consultant orthopedic surgeon in Hull, Yorkshire. He's our limb recon specialty chair. He fellowshipped in Belfast, runs a very famous Hull deformity course, and he's an avid photographer. He's also a cricketer, and that's a social snippet to him. And our co-chair is Dr. Firas Sulaiman from Jordan, and together Professor Sharma and Dr. Sulaiman will host the session, take us through the free papers, the series of lectures, and finally end with a riveting set of case discussions, which will put this entire topic into perspective. We at SICOT Pioneer strive to make every one of these sessions as interactive as possible. For the very global audience that follow us through this webcast, please post your comments, thoughts, any questions in the discussion box so as we progress through this webinar, so we may address them either between the talks or towards the end. The moderators and panelists will try and illustrate the key points and eventually summarize the gist of this webinar at the end through a summary slide. And on that note, ladies and gentlemen, thank you once again for joining us, and I hand over to you to our moderator, Professor Sharma. Hemant, over to you.
Thank you very much, Guy, and thank you, SICOT, for giving the limb reconstruction surgeons and the committee to bring forward slightly new and a little bit underappreciated, well, I will always say that, is a specialty in the world. So without taking any more time, we're going to start with 3 free papers and followed by some lectures. So first of all, can I invite Mohammed to present a paper on lateral femoral condyle advancement for severe genu valgum by Lazarov. This is something new kind of thing, which he's trying to describe something, a slightly new technique, which we not commonly used, although not unknown. Mohammed?
Hello. Hello, everybody. Hello.
Yeah, do you want to share your screen?
Yeah, I will. Yeah. Hello. Today I will talk about lateral femoral condyle advancement for severe genovalgum by Elizarov. Septic knee in children may lead to damage to the distal femoral epiphyseal plate as well as the physeal growth arrest of the distal femur. A deficiency of the lateral femoral condyle is an intra-articular deformity resulting in static and dynamic genovalgum deformity. Historically, this deformity has been treated using extra-articular osteotomy. Despite this require an overcorrection to obtain good alignment, there will still be residual deformity with abnormal joint line conversion angle. So the purpose of this study to present the technique and the results of acute advancement of lateral femoral condyle and metaphyseal osteotomy for gradual correction of the distal femoral deformity with femoral lengthening by Elizarov. Surgical technique, a L-shaped osteotomy of the lateral condyle with transverse limb 4 cm proximal to the intercondylar notch and the vertical limb through the notch. Then the lateral condyle distally advanced by laminar spreader for about 2 cm without the attachment of the soft tissue. Then transfixing the lateral condyle with 1 wire 1.8 and 2 olive wire to do compression perpendicular on the vertical limb of the osteotomy on a ring, ignoring that the wire not being parallel to the joint line. Another osteotomy, a metaphyseal osteotomy proximal to the previous osteotomy of the lateral condyle to do correction of the deformity and lengthening. Then begin the gradual lengthening of the femur and the tibia. After angulation deformity correction, lateral translation was mandatory as osteotomy rule number 3 was used. Actually, but the distal fragment tinting the unhealthy scarred skin, so it was mandatory to come back medially to avoid soft tissue complication. Results, the reserve was removed after 6 months after lengthening the tibia by 6 cm and femoral lengthening 4 cm. The mechanical lateral distal femoral angle improved from 54 to 98 degree and the joint line conversion angle improved from 24 to 1 degree. This X-ray after 6-year follow-up, we have normal alignment, but with shortening of the fibula, stable knee with negative stress valgus test, but limited knee flexion to about 45 degree. Deformity resulting from intra-articular etiology is often hard to manage. Using extra-articular osteotomy to manage intra-articular deformity will create an extra-articular deformity, an oblique joint with the resultant shear stress and often secondary instability. So condylar deficiency must be addressed differently. Conclusion, the lateral femoral condyle advancement with metaphyseal distal femoral osteotomy allowed correction of severe genovalgum due to intra-articular deformity after physeal injury without the creation of an oblique joint line orientation. This technique allows correction of the overall mechanical axis, restoring both the function and the cosmetic appearance of the limb. Thank you very much.
Thank you, Mohammed. Just wanted to ask you quickly a brief answer that what did you do with the trochlea? How do you ensure that the trochlear congruence is maintained in the patellofemoral joint and the patellofemoral joint congruence is maintained in the condyle advancement?
They have no problem with the patellofemoral joint, actually. The patient can bend to 45 degrees with full extension with just 45 degree flexion of the knee.
All right. Thank you very much.
Thank you.
Can I ask Dr. Borici to share his screen and he's going to present a treatment of leg length discrepancy with modular unilateral external fixator. Thank you. You're on mute, and you want to go on the presenter mode, or?
Yes. Okay. Do you hear me now?
Yeah.
Okay. Hello, everybody. Thank you for the presentation. I'll present my work of treatment of length discrepancy with unilateral external fixator. I do not have any disclosure in this work. What is the leg discrepancy? Is the inequality of the limbs that in most of the cases are from the etiology from the sequela of the trauma or from any congenital malformations. And the clinical signs are limping or joint pain, back pain, scoliosis, and movement restriction later. Just to examine the leg length discrepancy with initially with the Galeazzi test or block test, and the more accurate thing to do is to measure the radiologic examinations. And to talk about the treatment, it will be if the shortness is less than 2 centimeters, we can arrange it with high heel shoes. And if it's more, we have to consider the surgical treatment that in some circumstances, there are many options of lengthening the leg. And in our cases, we have used the external fixator in a population of 11 patients, 8 males and 3 females. And 2 patients have had trauma and 9 patients have had congenital problems in the tibia. In the tibia, we have held transversal osteotomy at the proper bone, fix it with a modular external fixator and available to increase its length. And we had begin after 2 weeks, after the osteotomy, we have begin with the lengthening 1 millimeter per day. The results are good, no pseudoarthrosis, and we have achieved lengthening of 5.3 centimeters, the maximum length that we had. This is an open fracture, femur fracture. As we see here, we have shortened initially, and then after the osteoregeneration begin, we continued with the lengthening process. The same situation in another femur case, shortening and then lengthening. And this is a 7-year-old boy that had some congenital problems in the tibia, and we have lengthening in 4 months. We achieved 3 centimeters of lengthening of the tibia. This is the girl that had 5.3 centimeters shortness of the tibia, and in 5 months we achieved the correction of this girl. Just to say that in all the cases at the tibia, we have lengthened also the Achilles tendon because of the equinus.
Do you want to put your summary slide? Yeah.
In conclusion, I had to say that the bone lengthening utilizing the unilateral external fixator is a good method that cost effective in resource-limited environment. It's simple and familiar, so patients can interact and collaborate to get the final result. Patients feel satisfied and ambulate without difficulty. Thank you.
So, Dr. Boris, just tell us that what is so different about your fixator? You said a modular fixator. Why is it different from any other fixator? Because it's a common procedure.
Yeah, thank you for the question. Because this is an external fixator that can make move in all the 3 planes. So if you have to correct not only angularly, but you can go anteriorly and posteriorly or in lateral position with it. So you can correct even if you do not have to straight all the length.
Oh, thank you very much.
Thank you.
A last paper is from Dr. Kakadia, and this is about the management of Charcot joint arthropathy with Elizaro fixator. Now, this is a very complex problem with the ever-increasing diabetic pandemic around the world. We're going to get more and more cases of Charcot and diabetes. Thank you for presenting your paper.
I'm sorry, just give me a minute. Good evening, everyone. Presenting the management of a Charcot joint arthropathy with a Elizaro ring fixator. So the introduction, the arthrodesis of a diabetic neuropathic joint is difficult and is associated with complications. The use of the Elizaro fixator in Charcot's arthropathy provides an effective treatment to improve both the clinical and functional outcomes and prevent foot amputation. So the methodology. So we have done a prospective study involving 14 patients. All the patients had presented with a deformed hypermobile ankle. The patient presented also with a peripheral neuropathy. None of the patients in this study had any chronic ulcers. The patients were surgically treated using a tibiocalcaneal or a tibiotalar fusion with an Elizaro ring fixation. A plain anterior-posterior and lateral radiographs of the ankle were taken pre and post-operatively. Post-operatively, after the removal of the implant, a walking cast was given and gradual weight-bearing mobilization was done. As for the results of the study, out of the total 14 patients, we have noted fusion to have been achieved in 12 of the patients. There was a stable pseudoarthrosis in one of them and an unstable pseudoarthrosis in another patient. The frame of time on a mean was about 21 weeks and the dynamization period was 2 to 4 weeks. The average follow-up was 19, done from around 88 to 36 weeks. Few of the X-rays of the pre-operative and post-operative and showing the surgical incision. So in the discussion with the Elizaro technique, we have managed to restore the morphology of the foot. In this study, there was no deep skin infection or any recurrent ulceration noted. No amputation was required. In conclusion, we could achieve correction and stabilization of the foot and ankle deformity with the Elizaro fixator, which allowed the correction of the deformity and also avoided any of the complications which usually are seen to occur with an internal fixation. It also allowed an early weight bearing, care of the soft tissue, and prevention of any amputation. These are the references. Thank you.
Thank you very much. It is quite a complicated and difficult problem, and you seem to have quite a good results. And with your average frame time, 21 weeks, and some cases only 13 weeks, which is quite astounding. Can you give us any tips as what are the tips you can give us for such good results and not too big frame time?
I think we have. It's important to have most of the patients in the study were diabetic patients, so we had a endocrine consultation, managed to get their sugars under control, and that was from the medical point of view. From the surgical point of view, I think proper maintaining of septic precautions and good wound care later on as well.
Thank you. So we're going to move on to our to the main webinar, and I'll request Faraz to introduce Professor Hosni.
Thank you, Professor Hemant, and good afternoon, everybody. We'll start the main webinar with our professor from Egypt, Professor Jamal Hosni. He is the ex-president of the International Assami and Bone Reconstruction Society. He is ex-president of the Egyptian Orthopaedic Association. He is the head of the Orthopedic Surgery Department, Benha University Hospital. He's the founder and the ex-head of the Bone Lengthening and Deformity Correction Center at Al Haram Hospital. And he's a pioneer of bone lengthening, bone deformity correction using Elizarov since 80s of this century. And he's going to talk about the global burden and dimension of the problem. Dear Jamal, please.
Thanks, Firas, for the compliment. Thank you so much. Thanks, SICOT, for allowing me to talk in this prestigious event. I'm going to talk about the global burden and dimension of the problem of limb reconstruction in resource-limited environment. Remember that the Earth resources are limited. It's limited for resources are limited for every country, for every people. There is no unlimited resources. So if you speak about limited resources, it's just you can compare between the limitation between different countries. So every clinical decision is also a resource decision. Coming to the resource-limited environment, something like India, like Egypt, or whatever, you have a growth rate about 3%, a huge one. 1/3 of the population is under the age 15. And you have high incidence of trauma. Perhaps there is 60% increase of the disabilities from road traffic injuries in the low-income countries in the next 10 years. And you have the victims of conflicts. You have conflicts in the Middle East, and you are facing many people with the problem of the injuries due to conflicts. Also, we have high incidence of congenital deformities. The average consanguinity rate is more than 30%. Not even that, you see these three sisters, not only 30%, in some countries, it's up to 50% consanguinity range. Besides which patient, when you think about limb reconstruction, we are talking about these patients. We are not talking about mechanical axis deviation for 5 centimeters or for 5 degrees or 6 degrees. We are talking about these patients. Also, these deformities, look to these deformities. If you think about deformities, we are talking about these patients. We have rare patients. We don't do animations because we have plenty of these patients of neglected deformities. So the choice of the treatment methods, according to the public health policy, so we have the cost-effective treatments. Perhaps this was one of the first publications about TSF in the world. We had 30 patients with TSF, with 30 frames, and we published our results. TSF is okay, but there is no comparison. It's the same. There is no difference between TSF and if you are a professional in doing the circular frame. The difference is it might cost more than 20 times more if you use the TSF, and the results are the same. Again, if you use magnetic nailing or something, I published it just 1.5 months ago. The complications of intramedullary nailing or the lengthening nails are almost similar. It's not true that we have better results than the use of a circular fixator. We made the analysis. So we treat the patient for the best treatment, but at the same time, taking into consideration the costs. Look to the English literature. The treatment protocols in the English literatures are directed toward the cases diagnosed at birth and recent trauma cases. So what about neglected trauma cases? What about neglected diagnosis? No protocols. The treatment paradigms of limb reconstruction education are coming from the English literature. Many publications, many classifications, most of them are based on animation, not real patients. Small number of patients over such a long period of time. I've seen a paper talking about pelvic support osteotomy with 8 patients done by 6 surgeons over 10 years. So each surgeon has the experience of 1 operation per year. And they wrote 25 pages about their experience with pelvic support osteotomy. Can you imagine? Experience, good judgment comes from experience, and experience comes from bad judgment. Too many publications, but small number of patients. What about the surgical load? Why on earth, when we talk about hip arthroplasty and knee arthroplasty, they always talk about the surgical load of the hospital or the surgical load of the surgeon? Why in the limb reconstruction and limb lengthening, I see coming from North America and Europe, people talking about that they have the highest experience in the world of doing limb lengthening and reconstruction, while they're doing a very few number of patients. The second problem with the English literature, that they give us the basics of treatment. Most of the basics are hypothetical. Like this patient, they said that if you have a non-functional foot, less than 3 rays, you have to do an amputation. Look to this patient, 1 toe and deformed with severe deformity. Like this patient, you see severe deformity. And we treated this patient, like you see here. And then look the way she walks with 1 ray foot. She's having almost normal function. See, the age 19. And now when she had a normal shoe, it's a sports shoe, she's running and she's walking with only 1 toe. Look the way she moves. The way she's running. And so when we talk in this area of the world about limb reconstruction, we don't talk about mechanical reconstruction. We don't talk about the mechanical axis. If you have a varus and you do correction and displacement, this is not the issue here in these areas of the world. We're talking about something else. We're talking about this patient after 5 previous operations who are ready for amputation, and this reconstruction. We are talking about Charcot foot and ankle, and dislocated joint, ready for amputation, and this is the reconstruction. Totally 180 degrees rotated foot at birth with very short limb, and this correction. It's just making a difference. It's not correcting the mechanical axis. This is TR syndrome. You see the patient lying down, and this is a walking patient. In conclusion, the instance of traumatic complications and congenital deformities seems to be higher in the source-limited environment. It's very difficult to define a standard way of treatment or guidelines. Complicated cases can successfully be treated by simple and inexpensive methods. We have a large number of patients, and we have up-to-date methods of treatment or the state of the art. Our mission is not to correct the mechanical axis or to do workshops showing the people how to improve the mechanical axis. We're thinking about changing lives of the people. This is what we mean by limb reconstruction. This is what we teach the surgeon here, how to change the life of the people, not to correct the mechanical axis. If we allow those people to publish, if we allow those people to show the world their huge experience with limb reconstruction, I'm sure that we are going to have paradigm shifts in the management of post-traumatic and congenital deformities. Thank you.
Thank you, Professor Jamal, for this nice presentation, and you strict to the time. Thank you very much.
Thank you, Kamal. I mean, it's a massive experience which you have, and I think each time I see your talk and your cases, I think it's amazing how difficult cases you have. So thank you very much for sharing that experience. Our next speaker is Dr. Mangal Parihar, and Mangal is a very well-known limb reconstruction surgeon around the globe. He's an honorary assistant professor in JJ Hospitals and Grant Medical College. He's very experienced, one of the top limb recon surgeons of India. And I have to say, he has amount of time he spends literally dedicated his life in putting an enormous effort for teaching and education. He was, I think, probably the first one to set up in the world this web chat. I've forgotten the name actually, and where the surgeons around the world will give opinion and help the surgeons with less privileged backgrounds and resources. He runs various courses and he teaches in a very different way, very involving, encouraging everyone and sharing the limelight with everyone. And he's an excellent teacher and speaker. So thank you so much, Mangal. And he's going to talk us about relevance of orthopedic forums and communication. Thank you.
Thanks, Hemant. So following up with what Professor Hosni was talking about is our environment is kind of limited and unlimited. What's limited? To a certain extent, the early knowledge, everybody is not equally knowledgeable. The standard of training is not standard, and it's kind of like a curate's egg. There are some places where there's a lot of good education, some places where there is not. So there's not enough expertise to treat all of those bad patients that he was talking about. At the same time, infrastructure may be deficient, implant quality may be an issue, and as he pointed out, costs, the affordability of patients, because here patients are, in a lot of places, patients are paying out of pocket rather than from insurance. But what's unlimited is, again, the kind of patients that he showed, patients who need reconstructive services. And these number of patients further burdens whatever limited resources we tend to have. But at the same time, the willingness to learn among our surgeons is kind of unlimited. The willingness to learn and the willingness to share, I think. So I'm going to talk about these few platforms which are, I think, relevant in terms of spreading knowledge, spreading techniques that we are using specifically, especially in our resource-limited environments. So email was one of the first things that came up with the internet. Today, Facebook is a place where a lot of people tend to interact. Instant messaging apps like WhatsApp, and probably what I consider most important is video with things like YouTube, Ortho TV, even CCOT has its own TV channel kind of thing. And I'm going to kind of compare it with face-to-face meetings, which have been a kind of standard, the erstwhile gold standard. So face-to-face meetings, they are fantastic for hands-on training. Nothing comes close to face-to-face meetings for that. But they are pretty costly to set up. To have a meeting is not an easy affair. And because of this cost, industry has to be involved in that, which is not always a good thing. And especially in smaller places like in India, where travel is difficult, it's not as easy for surgeons from smaller places who are in private practice usually to take a break and then move to a bigger city for this kind of conference. Oftentimes, especially the national conferences tend to be more of what we call a mela. It's fun, travel, a family outing. And those of you who have been to some of our national meetings will have been embarrassed and insulted by finding that some of the halls, where somebody has spent a lot of time traveling from abroad maybe or from another place, you find the hall empty with 10 people, 15 people. So there are advantages to it, but really it doesn't necessarily it doesn't tick all the boxes as far as education goes. So we've had what Hemant was talking about, India, which was an Indian mailing list when email kind of started. And there was also an international mailing list called orthopaedic. Here, the advantage of an email list versus IM or instant messaging is that measured and nuanced replies are more likely because you can take time composing an answer. At the same time, at the same time, because of the way that email is there, one case leads to a thread. So somebody asks a question like this about a grossly osteoporotic femur fracture, and then somebody else can reply to that. And then even if you come back, 6 months later, a year later, if someone searches for osteoporotic femur, they will be able to get this answer. And therefore, some kind of context is possible. Archives are available, even if somebody joins later on. So this becomes like a constant source of information / education. One of the big advantages is that this is asynchronous. So everybody doesn't necessarily have to be there at the same time. Somebody puts in a question when he is free. Somebody else puts in a reply when he is free, so that you are not forced to be in the same place at the same time. Now that's an advantage, but it's also a disadvantage in the sense that there is no direct interaction of the kind that happens in a meeting. The other advantage is that there can be a lot of sharing of literature in forms of PDF and written stuff, which will sort of emphasize your point or point out certain techniques, etc. The instant messaging is kind of now all pervasive. Anybody and everybody who has a phone kind of knows how to use WhatsApp. So as the word suggests, it's instant. Everyone is using it. It's quick and easy. It's asynchronous. Again, you don't have to be together at the same time. But it's more, I think, it can be used for help with a particular case. I've got this bad fracture, or I've got this bad case. What are the suggestions that you have to try and how I can deal with it? But in terms of overall learning and continuing medical education, I have a question mark in terms of how useful that is. It can also be used for sharing of literature. So it tends to be more of a image only. Either it is a horrible case which you put images of, or something that you did very well, you put a picture of, and there's no really nuanced discussion that happens on these WhatsApp groups, etc. So right now that limit is about 256 on WhatsApp and a few thousands on Telegram. Telegram does have a long-term archive, but on WhatsApp, somebody joins 6 months later, they won't be able to see what was happening, what were the discussions which had happened earlier. And oftentimes these groups tend to degenerate into good morning and happy whatever festival is going on currently, So it's not something which personally I think is very amenable to continuing education. I think what is going to stay for a long time is various kinds of video platforms, and the simplest and the freest sort of all of them is YouTube. Now here's one of the first video streams that I did was in 2017, and that was a talk on high tibial osteotomy myths and misconceptions, and that has had 31,687 views. Of course, a lot of these views may be people just dropping by and seeing, but if somebody is searching for high tibial osteotomy, an orthopedic surgeon, he would be able to listen to this whole 52-minute talk and interaction with other surgeons, which is, once I've done it, it's there for all time. I now have about 136 videos on YouTube, and this started 13 years ago. The first videos which I made for some kind of education, I would see to it that I put it on YouTube. So it's not a big deal, in the sense every time I make something, just upload it onto YouTube with a proper description. And over time, there is quite a big source of education builds up, and especially organizations like CCOT, etc., which you are already doing it. We are putting up, whatever discussions happen, you put it up on the web. That becomes a collection. So CCOT India actually, as early as 2018, had started this kind of interaction. And I had written then CME via the web. There was no inkling of the pandemic, but CME via the web is going to be, already is the way of the future for sharing of knowledge and techniques. So the big advantage it gives people like Professor Hosni and me, where we are held back in terms of finances and stuff. There's a lot of stuff that you can just put up and share without too much cost to yourself, which otherwise would need a lot of effort in terms. So you're doing a case that can be recorded with a simple video camera. Only thing, you have to take a little care to be sort of not too shaky and stuff like that. A little bit of basic editing, and you can share that up on the web, where somebody else who wants to see how this case was done, they can see it. So with video platforms now, you have the full power of text, audio, and video, and we know that audio visual is a great way of teaching. And depending on what you're doing, it can be synchronous as well as asynchronous. When you're having a webinar like this, there are people watching. They can ask questions. There can be a direct interaction. Even later on, when people come, they can watch it. So that's the asynchronous thing. And when there are 4 or 5 experts at the same time, they can discuss among themselves. There's a lot of nuance that can be brought out. Interactivity generally tends to be more useful as far as teaching or learning goes. So when you have interactivity, naturally the quality of education or the quality of learning improves. So this is probably the closest approximation to a face-to-face meeting without the cost and the logistics. In fact, tomorrow there's a face-to-face meeting going on in Bhopal where I was invited. I'm unable to go, but I'm able to participate in that meeting because of virtual, because of the webinar facility. So we need to think about, of course, whether this resource has to be free versus paid, whether it should be a closed group or an open group. Closed group as in only society members or people who have to sign in or log in. And then we look at whether we are looking for specialized areas where an arthroplasty association puts up arthroplasty stuff. Something like CCOT has multiple areas where they put in specialized stuff. Of course, it's not as good as a face-to-face for imparting hands-on training, but for imparting concepts, principles, basic knowledge, it's great. And there are now organizations which are coming up with what they call blended meetings, where before you have all the training, the education going on in terms of the theory and the principles, and then you meet just for that. So finally, social media and instant messaging is here to stay. I think web-based video discussions are also here to stay, and in the future they are going to supplement or complement face-to-face. So the only thing I would say is instead of KISS, keep it simple. I would say keep it free, because keeping it free, I think, is important to increasing its spread. Thank you.
Thank you, Professor Mangild. I think you exceeded the time by 4 minutes, but very interesting talk about a new era of education and the platforms for communication. Although face-to-face is still, as I think, and most of us think, is a good option. And during this pandemic, we learn a lot about the communication, and we start to teach ourselves abroad without face-to-face. Thank you very much, Professor Mangild. Dear Hemant. You are muted, Hemant. You are muted. Can you unmute yourself?
Yes. So our next speaker is Duray Naigam, who unfortunately can't be here. So there's a recorded talk of him. Duray, as you know, is a well-known limb recon pediatric surgeon from Alderhay in Liverpool. He's a senior faculty member in the BOA. He was an open tibial fracture committee, and he actually was one of the members who formulated the BOST guidelines. He's teaching a number of courses. He's been editor-in-chief of strategies in trauma and limb reconstruction, and he's now Emeritus, and also he has edited the Epley System of Orthopedics and Fracture, which is a well-known orthopedic book. He is an excellent teacher, and although he's a pediatric orthopedic surgeon, limb recon surgeon, he does a lot of adult work as well. So there's a talk from Durai coming, a recorded talk. Thank you.
Hello, my name is Durai Naigan, and I'm to present to you about using open access software for deformity analysis and simulation of corrections. It was only 30 years ago we were using pencils on hard copy film and goniometers, as well as tracing paper, in order to perform deformity analysis and simulations of deformity correction. The digital revolution has changed that. Photoshop introduced a ruler tool in the 1990s, and that was the beginning of using a publicly available software to enable deformity analysis and simulation of correction. So while the ruler tool in Photoshop allowed these measurements to be done on digitized images of traditional hard copy films, it was the introduction of a picture archiving system, PACS, in the 1990s that really allowed us to move forward with digital manipulation of radiographs. Very soon after the introduction of PACS, Bone Ninja, OrthoView, and Bone and TraumaCAD were proprietary applications that were launched that allowed digital manipulation of images, measurements of distances and angles that facilitated deformity analysis and simulation of correction. Several studies have confirmed a similarity of accuracy between the measurements made on digital films as well as those made on hard copy films. Furthermore, the digital measurements that are obtained from these images are as accurate as those obtained from CT scans. These applications share the ability to draw and measure lines, measure angles, cut portions of images to move them in order to simulate correction. These are properties shared by all these applications. And they have the advantage that many of these steps are automated. However, there is a significant price disadvantage. Let me introduce you to GIMP, which is an open source and open access software that allows you to perform all that is needed for deformity analysis and simulation of correction as can be done with the proprietary applications. This software is free. In addition, it is available for virtually the three main operating systems in use, Windows, Mac, and Linux, and the editing capabilities of this program exceed those of those proprietary applications. And most importantly, this program has the ability to use layers. The main disadvantage of GIMP is that the steps used in deformity analysis are not automated, but it takes about 2 days to learn the tools and the interface, and probably only 6 cases to practice before you are familiar with the program itself for this purpose. GIMP is able to draw lines on X-ray and measure distances should their X-ray be calibrated. It is also able to measure angles accurately. You can simulate corrections based around a Cora as you can with the other proprietary applications. Importantly, with GIMP, you can superimpose layers so that, in effect, you can measure distances, not just axially, but transversely, to measure the displacements of structures at risk before and after the simulated correction. The simulation of correction allows you to investigate different possibilities. For instance, you can first obtain a draft correction using all the rules of osteotomy that you are familiar with. You can then assess that proposed simulation in the context of how much surgery that is required and see if a similar correction can be obtained with a fewer number of osteotomies. And this, in effect, can help patients realize the objective of treatment with minimizing the amount of surgery needed. Let us look at an example. This is a complex deformity of the right femur. The analysis of the deformity reveals a resolution cora in the apian lateral projection. This would require a minimum of 3 osteotomies, should the intention be to fix this with an intramedullary nail. The simulation of correction shows that yes, it is possible to perform the 3 osteotomies and fix this with an intramedullary nail. But the simulation of corrections allow you to explore alternative strategies. For instance, on the images in the middle and on the right side, we have performed a simulation where the correction is performed at the level of the resolution cora, with excising the appropriate amount of bone and a shortening. However, to achieve the correct position of the axis, the AP correction would require a significant amount of lateral translation, obviating the possibility of using an intramedullary nail. But this simulation allows you to consider using alternative methods of internal fixation, like submuscular plating, as was done in this case. And as you can see here, the same method of simulation preceded the correction that was eventually done without using an intramedullary nail, minimizing the number of osteotomies and producing a correct final mechanical axis. So to conclude, we have available open access software that will enable deformity analysis and simulation of corrections for all surgeons who wish to undertake this. GIMP is free, it is available across different platforms, and it allows for editing capabilities beyond that of those proprietary applications. Importantly, it is also able to work in layers. Yes, there is a learning curve, and it requires manual adjustment where the previous applications are automated. Nonetheless, it offers an ability equivalent or better to those proprietary applications and is worth the time taken to become familiar with the tools and the interface. Thank you for your attention.
Okay, thank you, Professor Dori, for this nice and comprehensive presentation concerning the opening and using the software, and most of the new generation nowadays are familiar with most of the softwares marketed in most of the countries. To continue now with the next talk by Professor Sanjeev Sabharwal from USA. He's going to talk about the bidirectional learning opportunities. Just a brief about Dr. Sanjeev. He's a pediatric and young adult limb reconstruction and trauma surgeon. His clinical research focus on pediatric lower limb deformities, including a Plown disease, and he worked a full clinical practice, as well as he's the past president of the Limb Lengthening and Reconstruction Society, He also served as an examiner for the American Board of the Orthopaedic Surgery since 2010, and he's the sole honorary member of Pediatric Orthopedic Society of India. He served as a deputy editor of the Journal of Bone and Joint Surgery, and he is editor of a comprehensive textbook of the lower deformities in children. Professor Sanjeev, if you would like, please.
Thank you. Thank you so much. I'm assuming you can see my screen, right?
Yes.
Okay, so thanks, Evan. So yeah, my charge is to talk a little bit about bidirectional learning opportunities, and I'm glad the previous speakers have really built on this theme nicely. Okay, so I'm going to talk a little bit from my own personal experience, since I grew up in India and then moved to the United States, and my recent encounters with polio and polio-like conditions. What POSNA, the Pediatric Orthopedic Society of North America, has done in terms of promoting bidirectional learning opportunities. And then a recent couple of studies that we've done looking at opportunities for international pediatric orthopedic surgeons to come to North America for clinical observerships. So we all know there is a north-south divide, and Dr. Hosni and others have very nicely outlined that. And the question is, how do we address that? Sorry. So, I mean, there is a lot that we all can learn from each other. And I think that's the issue, that right now, a lot of it has gone unidirectionally. And how can we make that learning bidirectional so that surgeons in the high-income countries can also learn from their counterparts in other resource-limited environments? And there's a lot that's being written about it, including, you could learn about resource utilization, these focus factories where, like Gamal said, there's high volume and there's a lot of clinical experience that doesn't get shared for multiple reasons. How to come up with innovative solutions to complex problems that are low cost and high yield. And of course, the power of knowledge, like Mangal talked about. So, let me just take you back in time to polio. And, I was lucky enough to travel with one of my mentors, Hugh Watts, to Tajikistan, which is just south of Russia, neighboring Afghanistan and Pakistan. And there was, for political reasons, there was a huge outbreak of polio back in 2010. And I was lucky enough to accompany Hugh and his wife, Sharon, who's a physical therapist. Hugh's a pediatric orthopedic surgeon who still had experience from when polio was around in the US. And we saw a lot of children and young adults, or mainly children rather, with polio and polio-like condition. And this is where, you sort of say, this polio has been around a long time. And this is where I think bidirectional learning really, came full circle, because I had a chance to work with my mentor from fellowship, and the Tajiki surgeons had opportunity to learn from, from Hugh, and I, of course, learned from both parties. And then fast forward, we built on that, with the help of WHO, we organized a course in Tajikistan. I certainly was no expert in polio, but we invited physical therapists and surgeons, including Matthew Verghese, who again had a lot of clinical experience in India, to come and share this knowledge in Tajikistan. So it was like learning all around. Fast forward 2 more years, we did a course in the US at the POSNA meeting, and sure, this is where Hugh and Matthew and others talked about polio and polio-like condition. And the reason it was relevant is that while it wasn't polio, and the same kind of enteroviruses are coming back in US and even in Europe, where it's a condition that's similar, where people call it acute flaccid paralysis or acute flaccid myelitis. And the MRI findings and the clinical findings are very similar to polio. So I think this is where again, the bidirectional learning from polio helped all parties. And ultimately, with the help of Global Health, which is a educational platform, which is free access relevant to pediatric conditions, we all pitched in and put out this downloadable book on clinical management of poliomyelitis. So I thought that was a great story. And turns out that recently I saw a patient in my clinical practice who didn't have polio, but had a femoral nerve palsy as an infant, where unfortunately somebody was doing a inguinal hernia repair and tied off the femoral nerve. And when this was discovered, it was too late. She had quadriceps weakness, leg length discrepancy, and a slight valgus deformity. So, these were her x-rays. She had 5 centimeters of shortening, or 5.5, 6 centimeters of shortening. She had a flexion deformity. She was in valgus. So, clinically, like, okay, so this is not polio, but I learned a lot from my previous experiences, around people who knew about polio and talked about it. So this was our problem list, weak quadriceps, flexion deformity. There's already valgus in the femur. If you did an antegrade magnetic lengthening nail, you're going to make the valgus worse. And she already has flexion deformity. So from a mechanical standpoint, it's not going to be good to leave her in a flexion deformity at the knee. So this was one of our, options to do a 2-stage correction. We do a fixator-assisted varus extension, closing wedge osteotomy of the left distal femur first, and then do an antegrade nail. I mean, again, there's so many different options to deal with it, but just to sort of give you the whole spectrum of what, is available, we just did this, a fixator-assisted closing wedge osteotomy to sort of get her out of the valgus, overcorrect into slight varus and hyperextension at the distal femur. And then once that was done and she had regained her knee mobility, went back and did a little fixator-assisted magnetic nail to equalize or nearly equalize her leg lengths and restore her mechanical axis, and purposely left her about 0.5 centimeter short in order to allow for foot clearance with her weak quadriceps. So I think this is just one example personally where had I not gone to Tajikistan, I probably wouldn't have been able to apply some of those principles back in my clinical practice. Switching gears now to what has POSNA done in terms of similar outreach. And I think there's many things that POSNA has done. The couple that I'll highlight is, one is this alliance with the Pediatric Orthopaedic Society of India, and this bidirectional sort of learning started back in 2006. So every other year, a lot of North American faculty would go and participate in their annual POSI conference, and then also do some CME workshops around that. And not only did it, and like Mangal was saying, I think face-to-face still has an opportunity and a place, because definitely it helps with relationship building, some social acclimatization and cross-cultural exchange. So certainly this was bidirectional. I learned a lot about how to manage bone defects with limited equipment. And there you could see your CCOT president, past president, having a good time. The other part that I want to highlight is how POSNA started this thing called the Core Scholarship, where they would select 4 or 5 young trainees who had recently graduated from orthopedics and visit a few centers in North America. And I think I'll just highlight one such person, which is this person in the middle, Francel Alexis. And he was a Haitian surgeon who I actually met when I was in the Dominican Republic doing some outreach work there. And he was doing a fellowship there. And then he returned to Haiti. He had an interest in limb deformity, and he partnered with Scott Nelson and John Hudsenberg, wrote this nice chapter on deformity correction and limited resources. And now he's back in Haiti, and he's training junior Haitian surgeons with the help of Scott Nelson to do this. So I think this paying it forward is something that can be done in any platform, including CCOT. And finally, I want to share some experience about this international observerships that we surveyed. So we surveyed 181 international surgeons who over 11 years' time from 56 countries, most of them low middle income countries, came for a few weeks of clinical observership in one or more centers in the US. And this was their survey. It was blinded. So I think it was pretty, they had no sort of reason not to give accurate feedback. And I want to highlight that 99% of these surgeons said they shared this new knowledge and skills that they had gained with peers and trainees when they went back home. And 97% returned to their countries. So there's very little of this brain drain that's going on. And these were the barriers. And in terms of the barriers, we asked both the visiting surgeons as well as their North American hosts. I'm not going to go through the entire list, but I think financial burden was there on both sides. And of course, there was difficulty finding a North American sponsor, lack of observership. And I think the big thing for international surgeons coming to the US is that they don't have hands-on experience in the operating room. And that's something which I think we may be able to work on by either having scrubbed observers or have other ways of doing remote learning. And then, how can we enhance this experience? So these were a few things based on feedback and discussion and small group sessions, came up with some solutions. And I think some of this would be relevant to CCOT as well. Explore funding resources for these international clinical observerships, have a central repository or a bank where all these observership opportunities that are there in other countries, and that could go on both sides, both in the low middle income and the high income countries, where let's say somebody from the US wants to learn about neglected malunited fractures, they could maybe visit a place such as with Gamal and get some experience so that we can make the playing field a little more equal and everybody wins. Match clinical interests, pre-screen so that there's less issues with cultural and language barriers. Streamline onboarding so that there is no culture shock when somebody from another country comes to the US. Have a local North American champion, and this could go for any country.
Sorry, Sanjeev, would you mind wrapping it up, please?
Yeah, sure. Sorry about that.
Sorry.
Yeah.
Sorry.
No, you're good. You're good. Okay. So, and this is really my last slide or second last, that, these are the different platforms. And then this is just a plug for the Institute of Global Orthopaedics and Traumatology with the 4 pillars, one of which is bidirectional learning. Sorry, I went over time. Thank you.
No, that's absolutely fine. Thank you so much. There was a lot of things which we can take from. And in fact, Limb Reconstruction Society is trying to work with CCOT and try to develop our hybrid fellowships, which some of the things Mangal pointed out, and you put some in your talk and the study you did. And I think that would be quite useful for international fellows who can't travel, and the cost becomes a prohibitive, and they'll be fantastic for them. I think hopefully we should be able to develop that. Our next speaker is Nando Ferreira, who needs no introduction. He stands quite tall in trauma. He's the head of the tumor sepsis and reconstruction in Stellenbosch University in Cape Town. He does tons of work on infection, post-traumatic limb reconstruction, and he's the director of the Limb Lengthening and Reconstruction Fellowship at Stellenbosch University. He's also the founding member of South African Limb Reconstruction Limb Lengthening and Reconstruction Society, and he served as the president of the society from 2016 to 2021. And apart from that, all that, he works in absolutely wonderful place. And that's, I'm all jealous about it. But over to you. Nando is going to talk about value of the fellowship and mentoring. Thank you.
Thanks, Hemant. Sanjeev, sorry, you're still sharing this. There we go. Thank you very much. All right. Thank you very much, Hemant, and thank you very much to SICOT for the invitation and hosting this, I think, fantastic initiative. And I just hope this grows in future. And I can't agree more with everything that everyone has said before me. I'd like to just reiterate what Professor Hosni and Professor Sabharwal has just said. You know, I think there's quite a lot that the developing countries can offer, especially to the developed nations and surgeons from the developed nations, especially in the settings of trauma and limb reconstruction. So I actually think there's a lot that high-income countries can learn from resource-poor settings and lower and middle-income countries. And I'd like to make a plea to surgeons from both of those to consider attending fellowships in the resource-poor environments, because there's a lot of expertise, as you've already seen, as you know. There's a huge caseload in those countries, and the resource poor setting back to the high income country type setting, I think, is part of the bidirectional learning that we can still develop further. So I'm going to talk a little bit about fellowships from my point of view, from fellowships that we run in South Africa. So I'm from Cape Town in South Africa, and I work at Stellenbosch University. And I'm from the Advanced Orthopaedic Training Center, which is based at Tygerberg Hospital. It's our university hospital in Cape Town. And these are the type of patients that we manage. These are the patients that we and the community that we serve, resource poor environments in terms of patients where they have to go back to. And as you've seen from some of the previous talks, these patients require significant reconstruction, sometimes neglected trauma, neglected infected cases, big reconstructive cases, high caseload, and then the patients have to return to less than ideal circumstances. So it's a challenge on a couple of fronts. I was lucky to travel to Kyrgyz in 2011 to do a fellowship there myself, and learned a lot from there that I brought back and into my own practice. And then since then, speaking to all these experts in the field, learning every single day as we go along. So the Stellenbosch University offers a couple of fellowships, of which our trauma fellowship and then the limb reconstruction fellowship are the things that I'm going to focus on mostly today. If anyone wants to contact me who's interested maybe to come and have a look with us, my details are on the screen, and you're welcome. We offer a one-year limb reconstruction fellowship that runs from January to December every year. So we've been fortunate, we are very fortunate. We have a steady stream of fellows coming through our hospital, staying from short stays, a couple of weeks to a couple of months, to our formal fellowships that run a couple of years. And this is the type of diversity that you will see in our theaters. So the doctor in the middle is Will Harrison. He's my fellow at the moment from the UK. And then the rest are from South Africa, Germany, Libya, on various different lengths of stay with us. These are some of the other previous fellows that we've had rotating through the department: Australia, Norway, UK, India. So we really have a nice flow of different cultures, different perspectives that come through our department, which is quite nice. So in terms of fellowships, if you start reading about what a fellowship is and how you should set it up and the importance of fellowships, these are the type of things that you always find, that it's a two-way street, and these are the attributes that you need from the fellow and the fellowship director. And yes, although that is true and that those things are really important, for me, that is a given. If you aiming to do a fellowship and you go through all the effort to move to a different country, different state, different town, you're already going to have all those attributes in terms of drive and willingness to learn. And if you're going to be hosting a fellowship, you should already have all these other attributes that I've seen in terms of fellowship directors. So I actually see my fellowship and fellowship slightly different, where instead of it being a two-way street, I actually see it as a single track or single lane path that you're going to trod along. And it's the responsibility of the fellowship director and the fellowship setting the environment to provide the pathway. And that path is a teaching environment, the resources and expertise to teach, the academic standing in order to attract people in the first place. And then very importantly, case volume, case diversity, and enough support to anyone who attends those fellowships. Hopefully, initially, it is a high learning curve that you and your fellow walk that path together. And hopefully towards the end of the fellowship, it becomes more easily, and you can tend to follow your fellow as he completes his fellowship. And the end of that fellowship, the idea is that you and the fellow end as peers, that there's no mentor-mentee relationship anymore. These two individuals at the end of that year spent together, or how long that might be, end as peers and interact as peers, and have this peer level relationship for the rest of their careers going forward. So the things that I think that are important in fellowships, number one is skills transfer. And that is both in terms of clinical ability, clinical skills, surgical prowess, but probably more importantly in critical thinking and algorithmic decision making. So that is vitally important. Sorry, I skipped one there. So skills transfer. So this is again, it's one of my surgeons and one of my fellows, and he's applying a frame. And those are the type of clinical skills to transfer. But then those skills that they've learned at the fellowship, they have to take back. And we've just seen now from Professor Sabharwal how these individuals return to their own environments and take these skill sets that they have taken back and apply them in their own environment. This is one of my previous fellows, Dr. Yashwant Tanwar from India. And you can see him, similar things that he's learned when he was with us at Tygerberg, using these same techniques back at home. This is one of my other fellows, Dr. Saini, who's back in the UK now, and he's showing his senior there in London how we apply all-wire trauma frames in a trauma setting. So taking what you've learned and taking it back to that environment. So that skills that you've transferred during the fellowship needs to go back and be taught elsewhere, and thereby expanding the influence of a fellowship. Another really important thing that I feel is a must for a fellowship is that the fellow must become a teacher and an educator. And the reason they come for a fellowship is that they are on the path to become an expert in the field. So they should be able to teach what they have learned as well. And part of the year with me also is becoming a teacher and teaching. So this is Dr. Rudolf Fenter. He was one of my previous fellows, and this is him teaching one of the registrars how to apply a frame appropriately. So my fellows also are expected to become teachers. Again, this is Dr. Saini presenting academic presentations from his time with us at the South African Orthopaedic Congress last year. Another great advantage of the fellowship is the shared decision-making that lives for a lifetime after your fellowship. This is academic support, emotional support, and psychological support. Limb reconstruction is a draining speciality on the surgeon as well as on the patient. And I just want to show you, just from the couple of years that we've been running the fellowship, we now have a WhatsApp group with sharing cases between these different environments and getting different ideas, different techniques, sharing problems, sharing solutions, sharing literature in this WhatsApp group that we have between all my old fellows and current fellows, which is a great resource. And we all still keep learning from each other. Another important thing from fellowship is, apart from just the academic learning, is the growth and development as you as a person. We all know the saying that travel broadens the mind. So this is Dr. Tanwar on the top of Table Mountain. You can see the Cape, Table Bay in the background, and Robben Island at the background. So learning, traveling, opening your mind, being exposed to different cultures. This is Dr. Harrison with the potjiekos, which is a traditional South African dish, learning how to make potjiekos in our unit. So this exposure to different cultures and different ways of thinking, and different things that are important to people and different ways of approaching problems, I think is vitally important for you to become a good surgeon and a complete surgeon. This is another example of the current fellows in my department, and you can see the diversity amongst them. And this is them out one night to go and have a drink. So not only do the fellows come and learn from us as the hosts, they also learn from each other, and they share experiences of each other and where they come from, their resources, their struggles, their problems that they face. And this enriches the whole environment. And us as hosts learn all of these things from the fellows that come and visit us as well, and they enrich us and our training of our residents as well. So lastly, just to summarize, I think fellowships are vitally important, and there's so much value to them, to the fellows, as well as to the fellowship directors and environments where they are hosted. It should be a high volume area where there's a condensed training experience, that lots of experience can be achieved in a very short period of time. The fellowship should provide perspective to fellows, same problems that they might find in their own environments, but have different solutions, and see completely different problems that they haven't been exposed to previously and how that is addressed. The fellows need to learn decision-making algorithms as well as clinical skills. Those are obviously vitally important. And then really important is to become part of this network and this lifelong support and advice that you can get from a fellow as well as from the fellowship directors, and become friends and peers and colleagues in the long run. Thank you very much.
Thank you, Nando, for this talk. I think now most of the surgeons are proud of the place where they done their fellowships and with whom. In the past, they were proud of the university. Now they are proud of their fellowships and their mentors. So we are to continue our talk with our Professor Ashok Johari. He is a pediatric orthopedic surgeon from India. He is the current president of the CICOT. Previously, he has been the president of IOA. He is editor-in-chief of the GPO British, President Pediatric Society of India. He is excellent teacher and has been onward stage of teaching education for almost 40 years. And his talk will be about the role of CICOT in tackling the problem. Dear Johari.
Well, thank you, Firas. I'm very happy to be here, but one moment.
Take your time, sir.
I'll have to stop sharing. It's got something else. One moment. Okay. Well, thank you very much for this invitation. I must thank Hemant, and greetings to everyone on this platform and all those who are watching or listening to this webinar. Now, everything that I wanted to say has already been said, So for me, it is more like concluding remarks, and I know Firas will be happy because he has hardly any time, and I also have another webinar to participate in a few minutes. So what can CICOT do? The questions before us is, what is the problem? Number one, what can CICOT do? And what can CICOT do differently? Now, what is the problem? Actually, when we put up this webinar, and we are thinking of different facets of limb reconstruction surgery in the under-resourced areas, what are the problems which exist? Is it a lack of education, lack of training, lack of research, innovation, or infrastructure? What is missing? Well, based on this, Gamal already told you about the situation in the resource-poor countries, and other people have already spoken about fellowships and training modalities. I will take you on to the different roles of CICOT in this problem. Now, CCOT is a facilitator. It means that it facilitates many things like knowledge transfer from one person to the other, from an authority to a novice. For example, it can facilitate discussion and training. It can facilitate skills transfer there, and then it can facilitate knowledge creation. So jointly we can create knowledge by means of research. And then networking, of course, where man being a social animal, there's bound to be networking of sorts, but that's a great indirect way of learning from each other. So CCOT is a facilitator, it's a knowledge broker, educator, trainer, knowledge creator by means of research, and a networker. So what can CCOT do? It can partner with its members for education, for training, for research, for innovations, and maybe for infrastructure also. So education and training, we have heard all the speakers talk about education and training, and CCOT does it in a number of ways. So you have the curriculum. I'm encouraging Hemant to form the actual limb reconstruction curriculum so that super specialists can be trained in limb reconstruction, and then they can demonstrate their competency, and then we certify them to be competent in that field. So we could do courses, workshops, webinars like this one, lectures, simulation exercises, hands-on training, live surgery, case discussions, fellowships and mentorship. Again, a lot has been said on this. And then something very important is on-demand education to fit the time I have available to learn. So this webinar is an example of what CCOT is doing. It's gathering together people from different parts of the world and sharing a world perspective on a focused area or a focused topic. Here it is limb reconstruction. So as a knowledge broker, we utilize didactic, digital, and hands-on formats. And then we can actually customize knowledge so that there is appropriate knowledge for appropriate segments, and certification is what I mentioned. Now, these days, the demand is for education 24/7. Whenever convenient to a member, he wants to be educated. So education has to be available 24/7. It could be didactic, it could be digital or blended learning, as was mentioned earlier. Now, CCOT is going in for a learning management system, which means you have education flowing 24/7. World-class training is possible. Self-paced learning is possible. Continual learning is possible. Your performance can be checked, and competency framework established, ultimately leading to a certification. And then it can have an up-to-date content as a repository, as was mentioned by Mangal. For training, CCOT can arrange skills training. You can have live and cadaveric surgical courses, hands-on workshops, sawbone workshops, surgical videos and interactions with the creator of those videos, surgical teams in remote and disaster-ridden areas. CCOT can participate in disasters, and that is again a very, very sort of great way of learning and teaching. So certification is what I mentioned. Artificial intelligence, virtual reality, and simulation technologies. So all that is possible. So CCOT can help member skills, sharpen the member skills. So these are CCOT cadaver courses, which can be done. Simulation training can be done. Now, what can CCOT do besides education and training? We take over research, which no one has spoken about today. One of the reasons why the underdeveloped countries are not known for their prowess is the lack of research. We're not publishing enough. So CCOT can act as a knowledge creator by promoting research and innovation, by webinars and courses on research methodology, multicentric research, survey research, research grants and applications, and awards, for example, research mentorships and meet the researcher. Innovation is another area which CCOT can promote: cheaper method, cheaper technology, innovation for local needs, innovation research, and publications arising out of this innovation research is very, very important to disseminate knowledge. What can CCOT do in terms of infrastructure? Well, CCOT has advocacy and disaster relief committees, and efforts are there for advocacy and disaster relief. And then there are CCOT social channels, organizations which are partnering with CCOT. Example, the World Orthopaedic Concern can really go into the resource poor countries and actually share infrastructure with them in terms of the equipment, for example. Now, networking is another role for CCOT. What CCOT does is bring members together. It promotes interaction and exchange like is happening now. It arranges for interaction with leaders in the field, fellowships and awards, mentorship, and reverse mentorship, as was mentioned, conferences, inspire members in different ways, example, the Lifetime Achievement Awards, best papers, best research, etc. And CCOT also provides industry interaction. Now, the third question is, what can CCOT do differently? There are many organizations and many associations. So how can CCOT do its work differently? So important here is to note that CCOT has a global reach. It can reach grassroots, example, through partner organizations like the World Orthopaedic Concern. It can help in preparing for disasters and for supply of equipment. So CCOT can help in almost all facets which are important, for developing this particular branch, especially in resource-poor environments. So to conclude, the problem needs to be defined clearly. What is missing? We need to know what is missing. CCOT can help in its different roles, whether education and training, research and innovation, or infrastructural help. CCOT as a global organization is eminently positioned to take limb reconstruction to resource-poor environments. And one suggestion in the ending is for CCOT to have actually within the limb reconstruction section committee, a resource-poor environment committee, which can actually come up with guidelines and which can come up with training modalities and manuals for people from the less resourced areas, and that can go a long way in training, because generally this sort of training does not find itself into textbooks, which are written by the West, which actually have a different type of problem altogether, as was mentioned by Gamal. So thank you very much, and I'll stop sharing here.
Thank you so much, Shok. That was.
We can have a discussion if you like on any of these aspects, but we are short of time.
I think probably, yes, I think we'll have to forego that the discussion. We are running a little bit behind. And so I'll just quickly explain how the case discussion will run, and then Firas will introduce the speakers and we'll start off. And basically the speakers will give you between 2 to 4 minutes the case and what they have done. And then other 3 speakers will give the 2 minutes their view and their logic and how they would have things differently and why they have done differently. So hopefully we should be go at least 2 cases, and then I'll finish with a summary of the webinar. Thank you. Firas.
Okay, because we are behind the time, I would ask Professor David Ferguson to start sharing his case. David is a consultant orthopedic surgeon at James Cook University Hospital in UK. He is a non-surgeon dealing with limb reconstruction concerning pediatric and adults. Dear Dave, sorry.
Thank you very much. This is a case highlighting major trauma that presented to my unit at James Cook Hospital in the north of England pre-COVID. So it's regarding a guy who was 78 years old. He was a male with many injuries. He came off his push bike at high speed and he hit a wall. He had a skull fracture, an open 3B tibia fracture, which will be the focus of this case discussion, alongside a femur fracture on the same side that was closed, but unstable thoracic spine fractures and bad chest with flail segments and bilateral scapular fractures and clavicle fractures. So he underwent initial damage control. He went from the emergency department with this open tibia fracture for a washout and external fixation, but he also had further damage control procedures to his chest to help his ventilation and also to stabilize his spine within the first 24 hours. During this first stage procedure, he became very unwell, to such a degree that he was placed on a ventilator, intubated, ventilated, and eventually had a tracheostomy, and he ended up with inotrope support. He was ventilated on life support machine for a total of 2 months. The significance of this was that our intensivists would not let me touch him until the 2 months was up and he was able to be extubated and transferred back to the wards. So there lies the problem, an open tibia fracture that we had to manage open, essentially in an intensive care unit with infections. He had an X-fix on that became infected. We had to take that off on the unit. And our British Orthopaedic Association guidelines advise us that we should be trying to treat these injuries for definitive soft tissue closure within 72 hours. But this was not possible because of his health requirements. So he had these wounds after 2 months on his leg. The granulated tissues, but underneath that was a bone that had not healed. And it's at this point really that the case discussion really starts as to what we should do about this tibia that's potentially been exposed to infection, it's not aligned, and this is a man who's recovered from all his other injuries so far. So my plan was to take him back to theatre as a joint case with my plastic surgery colleagues and do this as a combined procedure where we would excise out any bad tissue and bone. He'd already lost 2 centimetres of bone at the initial debridement on day 1, and then he lost a further 2 centimetres, which I was unhappy with, unhealthy bone inside, along with some unhealthy skin. And his skin was how we describe it as tissue paper skin, very thin skin that didn't have much give in it. When we were in theatre, one of my initial plans was whether I was going to do some bone transport to make his leg the correct length and restore his alignment at the same time using circular frame. But I changed my mind. When I realised that the leg could be aligned and we could get a medullary canal, I elected to put an antibiotic-loaded tibial nail to restore his alignment, promote early rehabilitation. And my plastic surgery colleagues applied an anterolateral thigh flap, which you can see being harvested on the right image. So that's before and after to show the alignment after he'd had his tibial nail with antibiotic coating on. And there he is just over a year from follow-up as well with a 48mm block under his leg, but shoe raise and now cycling again with an adapted bike and pedals. So that is the case. There's some learning points from my side, but I'd welcome discussion.
Very great and nice case to present, and we want from the audience or volunteers to talk about if this case took place in India, for example, or in Egypt. Would the management be the same resources?
No.
Do we have the same resources, dear Jamal? What about this?
This case ended up with valgus ankle and shortening, and we don't consider it as a good result, actually. So if if you had the same patient, we would have done resection of part of it, shortening to decrease the soft tissue defect. And we do the corticotomy first technique. We start the operation with applying the frame to the proximal part and doing corticotomy, and we isolate the distal part. Then we go to the distal part after we do the corticotomy. We do some resection. We close the wound. So we make the defect smaller. Then the plastic surgeon will do rotational flap. Then we put the frame distally and we do acute compression. And we continue lengthening of the tibia till we get limb length inequality. So we wouldn't do it the same way for the tibia.
Right, but Gamal, one of the things was that in this case, the patient wasn't very well, so long surgery was at that time was not feasible. So, Jen, how would you do that?
For us, it's not a long surgery; it's a short surgery.
Okay.
It takes perhaps the same time like you do interlocking nail, and perhaps shorter interlocking nail and rotational flap. And the rotational flap are done by the plastic surgeon, who's he's a professional in doing such things with the presence of the circular fixator.
Jan, how would you do that?
I told you we do it the corticotomy first technique. Yeah.
Sorry, I was asking Jen. No, I was asking Jen Gamal. Sorry.
Okay, sorry.
Sorry.
Thank you for asking me to participate, Herman, and thank you for my opinion about the case. I think taking and having a 78-year-old patient to begin with 8 plates on his ribs and all the other issues, I think it's a wonder that he survives in any circumstance. I think we use a lot of lengthening nails and also the TL-Hex, TSF, and regular Ilisarov. I think for us, plastic surgery and the initial take to it is pretty similar to the UK. So if we have plastic surgeons available, we try to use it close. Then I really appreciated the talk by Nando, who have also been fortunate to visit and gain some of that experience and what's possible with open bone transport and closed bone transport and so on. But I'd probably go with a circular frame and acute shortening as well for this one. That's two months down the road. Of course, tibial nails and antibiotic coated ones, either commercially available or that you do it at home, is an opportunity. But I think, as Gamal said, proximal lengthening and distal shortening and compression is probably also my go-to approach for that one. And that can be accomplished with pretty simple means.
I think generally people would do that, and I have to also mention that antibiotic coated nail costs about £2,500. So it's not available even in UK in every hospital. But I think this is this is one of the options actually, that if you have a situation where you think you can get away with it, it's easier. Although for most of us, I have to say, a circular frame with shortening and proximal lengthening would be the way, especially 2 months old. Vasu, would you have done anything differently? You're on mute.
I think I'll do only Elizro, as you said, without even a plastic intervention.
And so how would you deal with the wound?
The wound will naturally heal. Once you stabilize the body part.
See, the part of the problem is patient is unwell. He's so unwell that the anesthetist is saying, we are not happy to anesthetize the patient. So in that case, you have to just wait and watch. So what would you do with the wound?
The flap will take about at least 2 hours, no? The flap surgery is 2 hours.
But the anesthetist is not happy.
Yeah, the flap surgery in my institution, in the best hands, it takes about all day. It's about 6 hours. Slightly unfair as well is another confounding factor is on the workup to the flap surgery, we get an angiogram, a CT angiogram, and they noticed a filling defect in his bladder. And when they looked at it a bit more closely, they found that it had been there in a previous scan very, very subtly, and he had a bladder cancer. So the day before surgery, I was told he had a bladder cancer, that he was going to undergo some chemotherapy. And so would that change now any of your decisions about whether you're going to try and have regenerate bone, knowing that he's going on chemotherapy?
Anyway, that is a good option.
It depends upon the type of chemotherapy. You have to ask the oncologist, because we thought before that if the patient is on chemotherapy, you cannot do bone lengthening and the problem with the regenerative, but now it's totally different. With some treatments, there's no problem at all. If you do lengthening, the things have changed in the last few years with the chemotherapy.
Now, I think it's a fantastic case to sort of have the variety of options. And I think the situations vary, and sometimes it is when you are at it and you're, I mean, I have to say is the same that a flap in our institution will probably take all day. If we start on time, we'll finishing about 4 or 5 o'clock. I mean, the local flap might take a couple of hours, but all free flaps in our institute will take about 6 to 8 hours. And I think it is very, very remarkable if your plastician can do 2 hours, and some surgeons do it. But I think we have to also look at it in general, that overall condition of the patient as well, which I think is also important. Jan?
Yeah, thank you. I mean, just picking the brains of the ones that use Lisarov in Egypt and India, is there any age limitation for you to consider, like a tibial lengthening with an external fixator? What are the limits?
We don't have limits. Why do we have limits?
I was just wondering whether you have like an age limit or a set of comorbidities.
Even if he's 97, it doesn't make any difference. No,
But Kamal, the quality of regenerate as they grow old, I mean, I have noticed that over 60, I'm very hesitant to go any lengthening, and certainly not than a couple of centimeters, because the quality of regenerate takes so long and so poor that the frame is there for a very long time.
I've done 84 atherosclerotic vessels and everything, you know, the so-called contraindications, but there was no contraindication. These are hypothetical contraindications. You know, it looks like humeral lengthening when they say don't do humeral lengthening before, because there is a possibility in unstable shoulder, because there's a possibility of dislocated shoulder. But this is hypothetical. Never happened. We didn't see cases with humeral lengthening with dislocated shoulder. It's the same thing. It's the same. It's just hypothetical fear of the problem, but it didn't happen.
But Kamal, I mean, I think the experience in your experience that has worked well. But in generally, my experience and some other people experience that lengthening an elderly, sometimes we leave them short, give them a shoe, they are much happier than having a lengthening and a complex long frame. So
I agree with you. If we do lengthening, and after 3 centimeters we have a weak regenerate, we go back and do shortening and so on. So it's not a final decision. So if we say 4 or 5 centimeters and we do corticotomy and have problems, we go back. So we
fantastic.
It's not a final decision. So
okay, right. Let's move on to the next case.
I don't prefer lengthening beyond 70 years. If at all we do at a very slow speed, like 5 mm a day, 0.5 mm a day. And
even then we struggle. Right, Vasu, let's move on to the next case. Do you want to present your case, please?
Thank you. Yeah. Yeah, this is a brain teasing case. Can anybody guess what is this deformity is? He is looking forward, and he was referred to me like a complex deformity with various sorts of hip and knee and ankle deformity. So as customary, you cannot take a full length X-ray. It was impossible because she could not stand forward and you cannot keep the patella forward. So full length standing X-ray is impossible. So because since our X-ray investigation was found difficult, we have to rely upon our clinical examination more than X-ray evaluation. So I palpated there, found the tiny patella and derotated the limb to keep the patella facing the roof. It was amazing. It just got transformed into a pure genu valgum. You can see the X-ray. You can see that X-ray that was an AP X-ray which I got. Yeah, this was the X-ray after making the patella pointing the roof. You can see the extreme valgus deformity, distal femur valgus. And her natural comment said she flexed her knee, hip to bring the foot onto the floor. So that was how she was keeping it. and it was an illusion that 180-degree torsion has happened. So I'm not running the video because it takes time. So this was the planning which I did, a proximal axis and distal mechanical axis. It is not meeting anywhere on the bone, far below the ground. So the cora was far below the ground. So I made a middle line, and you can see 65 degrees there and 105 degrees here. So totaling 170 degrees of distal femur valgus. So as we have planned, I need one osteotomy at that level and another osteotomy here. 2 level osteotomies. And here the problem is, it is not been reported such severe genu valgus in the literature or its correction. So this was my planning on my Bone Ninja. So the expected problem was how to make a pre-assembly for this complex deformity and how to control these 3 fragments, the one fragment, middle fragment, and distal fragment, by a stable frame, and how to place hinges and how to place distractor here, because you cannot keep distractors here. There is no space for anything. And she was probably having IT band tightness. How to release it? I cannot even put a hand in between here. There's no space. So vastus lateralis contractures and chances of peroneal nerve palsy, I could not release the peroneal nerve there. And I don't know what is going to happen to vascular problems. And how to do the reference wire in the femur. You cannot put a reference wire. And how to do osteotomy from medial side, not from lateral side. I cannot do, commonly we do osteotomy from lateral side. Here I have to do the osteotomy from medial side. And almost all pins have to be on the medial side. So all these were the problems. And I marked the femoral artery by a Doppler. But as you prepare, the marking will go. So I made henna or mehendi over there that was staying for more than 2 weeks. And that was the frame which I made. You can see the olive wire, cut olive wire from medial side, proximal, and did one osteotomy there. I did another osteotomy at this level. And you can see it is gradually coming out. So that was the original frame. In between, I added the half inch in between, I added later on. So they become straight. From the before and after. So this was how she was walking. This is, now she is walking like this. And this is after 6 weeks of removal of the frame. It took 11 months for correction. So take home message is, so nothing is impossible. Even if it looks very crooked deformity, you can still correct it. You can get good mechanical axis. You don't have to just improve it. We can make a perfect mechanical axis correction. Have a strong basic knowledge about a stable frame. We must have good clinical skills, proper evaluation, imagination, and planning. And most important thing is willpower and courage, and know our tools. And always see it with your brain and not with our eyes. Thank you.
Thank you so much, Vasu. That was a cracking case. Jan, any comments?
Yeah, it's just a true of what the magic of Belisarov can do, right? So it's just one case I've seen similar in Knut Christensen's hands, who has also been to Kurgan and has been my teacher in Aalborg. And like having those really severe deformities, of course, there's no room for a nail. And mapping out the structures of risk, I think, was really intelligently done. I don't have access to henna.
No, I think that it emphasizes the point that preoperative planning is probably one of the most important things. Sanjeev, any comments?
This is.
No, I think it's fascinating, and this is exactly what it is. It's such a befitting ending to this symposium because it just captures the whole theme that the principles are universal and grounded in good knowledge and analysis. And just like with the henna example, it's innovative, it's effective, and it's actually better than the magic markers that we use around the world. So really well done. Congratulations.
Thanks.
I think, to be honest, whosoever does it, I don't think, Vasu, any of us will disagree with your sort of, wherever you are, you will have to do one way. Gamal, yes, sorry.
This case represented the limited value of the measurements we do on the X-rays of the appraisal of some deformities. Remember that we created the apex of the deformity, the cora, the mechanical axis. Those are our measurements. This case is exactly the same like cases, neglected cases with osteogenesis imperfecta. And it's not C-shaped deformity, it's half a circle or more C-shaped deformity. And if you want to correct it, you have to do 5 osteotomies or 6 osteotomies because you have too many coras or apices, which is impossible from the clinical point of view. It was also impossible for my friend to do the mechanical axis or something like this. And he represented the way you can, in severe deformities, do clinical judgment. And he did clinical judgments. You don't have to do your osteotomy in the core or something like this. And sometimes, especially of the hardware problems, sometimes you do 1 osteotomy or 2 osteotomy. You need 3 or 4, but you have 2. And at the end, you have better clinical access, better clinical results, and forget about perfect mechanical access and these expressions because it won't work in such a case. Excellent case, definitely. Yes.
No, definitely. I think, Gamal, you're right. I think we should not be sort of focused only on the numbers. I think clinical evaluation, getting the deformity from patient's point of view, the angle is 80 or 90, doesn't make a difference as long as the leg is straight, they can walk. I think numbers are useful in terms of our measurement and for planning, but we have to also consider, as you rightly pointed out, that numbers are not the only thing. It is a combination of things that we should aim at. And I think the patient's function and the alignment is the most important. So on that note, I want to just quickly summarize. Sorry.
Let me add one just point.
Sorry, Firaz, I wasn't ignoring. My apologies.
No,
sorry.
The new technology of 3D printing sometimes helps in sophisticated and complex deformities. And I think in the future, 3D printing of a complex deformities will solve many problems and make planning very easy. And we start doing that in a few cases of complex deformities. Just this is a note for everybody. I know most of you is aware of that.
Thank you so much, Firaz. Thank you so much. Is there, I'm sorry, my apology, I should have asked, are there any other comments before I just summarize in a couple of minutes? Thank you. So first of all, thank you so much for all of you for taking the time and presenting such a fascinating webinar and the cases and the points you raised. And I think they will be quite useful in the future in terms of developing Limb Reconstruction Society curriculum and the hybrid and fellowships and help educate and teach and spread the knowledge within our colleagues. Started with Gamal, who pointed out that how big is the problem and is that the complications and the congenital deformities seem to be much higher in the resource limited environments, and the number of things he pointed out on that. And he's quite clearly emphasized that it is, you can't just follow numbers and a one way of treatment. You need to have a variety and an open way of looking at these things. And he also pointed out that you don't need expensive gadgets, which we use all the time, and you can have simple tools, inexpensive methods, and can get equally good results. And there is a paradigm shift in the management of these injuries, particularly injuries, post-traumatic and congenital deformities. Mangal, who's been been using this number of tools over the years and helping people out, he pointed out that the social media and instant messaging is not going anywhere. We better get used to it. And same as the web-based discussions and videos. And you pointed out the importance of the face-to-face as well. But I think it will be the hybrid model, getting the best of both would be the way forward. And he said that not everybody is comfortable with the virtual meeting, but they will continue. So it complements face-to-face. And I think what we need to do is get used to the idea that it'll be the combination of ways we do our meetings and spread the education. Then Dorai pointed out that there's a lot of freeware which is available, and he gave an example of GIMP, but there are others freeware available as well, and it can help us all plan, and it will help us in a very expensive way treat our patients. And although it requires a learning curve, but these are quite flexible applications and which will hugely help our patients. Sanjeev then pointed out that through his work and his experience that we can learn a lot of lessons from the low-income countries. They have a lot of experience in these complex cases, and I think with the remote learning possibilities, and also he pointed out that the solutions which are available in the low-income countries are equally applicable, and HIC with perfectly good results. It's just the way of application of the principles and learning from each other with an open mind. And the societies like POSNA and other societies can be instrumental when you can in developing the bidirectional learning opportunities. Nando pointed out that he has a lot of fellows, and he said that condensed training and learning with the high volume cases would be quite useful. And you can look at the same problem in a different way, have different solutions for the same problems, and we can have algorithms based on our skills and opportunities, and our resources, and they can work equally well. And part of networking, learning from each other, and interaction is a very important part of fellowships and mentoring, I think, and that should be encouraged and constantly improved. Ashok Jory pointed out that how CCOT is helping as a facilitator and a broker in a number of ways, and is working to customize knowledge for the individually as they need it, when they need it, 24/7. There are a number of things CCOT is doing. They have good infrastructure, and with collaboration, they're in the right position to develop and disseminate education and information. And I think Limb Reconstruction Committee is quite poised to it. We have a number of discussions, and hopefully in time we'll be able to deliver a lot of education, especially in limb reconstruction where there are no textbooks, and the knowledge transfer would be very critical. So thank you so much, everyone, for giving the valuable time. I enjoyed it. It's a fantastic webinar, and thank you so much. Sufyan, you want to show a couple of slides before we go off? So there are a couple of slides about the survey, and if you fill in the survey, you will get a certificate for all the delegates. Our next webinar is on scaphoid non-union on the 14th of November. I think CCOT is moving to the case-based webinars rather than didactic lectures. Please join us in that. We won't be there, but upper limb surgeons would be there. Thank you so much.
Thank you. Thank you.
And Firas, thank you so much for your help.
Thank you all.
Thank you.
Thank you. Great webinar. Thank you. Bye.